the opportunity to go through some of our wisdom results and also some of the planning we're doing in terms of next steps with those results. And again, if you have not yet, please introduce yourself in the chat. We'd love to see who's here and where you're coming from. But for our community forums, the general format for these is that we really do want to hear from you. So if you have questions or want to clarify something, please don't hesitate to put something in the chat or raise your hand, or if there's sort of a pause, feel free to speak up and ask your question. We really do want to make sure that we get people's questions answered in real time while it's top of mind and relevant to part of the presentation. We'll also have some time at the end for some questions and answers. These forums are recorded, and the purpose of that is so that we can share them to others who aren't able to join during this time frame, and we can share out the link to people if you know others who might want to see it who weren't able to join today. And then at the end, we do have a short feedback survey so we can hear what you thought of the presentation, if there's some suggestions or other areas or topics that you want us to focus in on in the coming months. So the forums we've been doing for the past 5+ years really are an effort to try and move together toward equity and better outcomes in women's health and breast health, especially for everyone. And so we've had a variety of topics over the years. This is just a lot of them condensed into larger topic areas. And if you go to the YouTube channel where these are posted, you'll see a whole library full of presentations from the past. So we'll put that link to the YouTube channel in the chat if you want to check those out. But lots of topics around women's health, the wisdom study in general and what we're trying to accomplish. Also in risk assessment and some of the components of the risk assessment, and also topics around screening and diagnosis and treatment. So what we are discussing this month are our results from the Wisdom 1.0 study, and we'll go through sort of remind everyone what that study was and what some of the features and study design of that study included, and then we'll go through some of the results. This was presented back in December, but we do have some additional results that have come out since then, plus some focus in on what are we trying to do next, where do we go from here, and how can we try and use these findings to change practice. So that is the goal for today. So we have Laura Esserman on, our founder and lead and champion of the Wisdom study. She also is the lead of the UCSF breast clinic here in San Francisco. She not only leads the Wisdom study, but other trials as well, including the I-SPY trial and the RECAST trial for DCIS. So without further ado, we will let Laura take the helm and reflect upon the Wisdom study, past, present, and future.
Hi, everyone. So I know some of you have heard the results. We've gone through this before. I'm just going to briefly go over them and maybe put them into a little bit of context of thinking about what made the study so hard to conduct, how we have to sort of face confronting bias, and how we build culture in a diverse community, and really sort of thinking about next steps. And that actually is hard. The next step of trying to build on Wisdom and to get this into the standard of care is actually as hard as running the trial. So I think it's worth a discussion about that. And Allison, you can monitor the chat. Please stop me along the way. If anything I say doesn't make sense, please, let's try and make this a conversation. And so that if there's something that I haven't, isn't clear, I'm happy to clarify it as I go. So let's go. So next slide. So just to remind everybody, PCORI, this trial was funded by PCORI. It was a pragmatic trial. What does that mean? A pragmatic trial means that it's not where we got every piece of data and people came in. We are trying to do it as a more of a real world evidence study where we assess people's risk, made recommendations, and let them do what they do and see how it worked. And, with the caveat that not everyone was going to follow the recommendations, and the data wasn't going to be perfect. but it's really trying to get a sense of, does this approach make sense? And what we were trying to do was include any woman 40 to 74 who had not had breast cancer before. We invited people to be randomized, in which case they would be assigned whether it was risk-based screening or screening once a year starting at 40. Now, not everyone wanted to be randomized, and we know that that's true, and that alone can introduce bias in a study. So we allowed those who did not want to be randomized to be in what we called an observational group, where they could select whether they wanted risk-based screening or annual screening. We were told when we started this trial that no one would choose anything other than annual screening. That's what people wanted. And so this gave us a chance to understand who would choose which arm. And without this, we wouldn't know that. So next slide. So again, what was in our comprehensive risk assessment model? We used the Breast Cancer Surveillance Consortium version 2 that has age, race, ethnicity, family history, biopsy history, and breast density. Breast density is read by the mammographer that, A, B, C, D, whether you have fatty breasts, scattered density, moderately dense, or extremely dense. That's what the radiologist reads. So it's a kind of a semi-quantitative, qualitative assessment of people's breast density. We look for 9 breast cancer genes that include BRCA1, BRCA2, PALB2, and 6 other genes. We were looking for specifically whether there were pathogenic variants, meaning an error in the gene that was cancer causing and that was known to be cancer causing, would increase people's lifetime risk of getting cancer. As well, there's a whole bunch of other genes that we inherit. We've talked about the SNPs, the single nucleotide polymorphisms, meaning all these other genes that you inherit, some of which none of them went on their own mean very much, but together, combinations of these many genic gene risk. So polygenic risk could either increase your risk or decrease your risk. At the time we started the trial, there was reports on 76. By the time we ended the trial, there was several SNPs, hundreds of SNPs that come together, and that field has continued to improve. We added improvements every year because we didn't want the trial to be obsolete. By the time we went out, and every year we reassessed everybody. So we wanted to make sure that we were building a trial that would be built to last, right? From all this information, we put it all together to give people information about their age to start, their age to stop, how often to screen, what modality, meaning MRI or mammogram, and what the risk was and how they could reduce it. Okay, so next. So again, we got breast density from the mammogram report, we got the other information from a health questionnaire, and the genomic profiling came from spit kits that we sent to people's houses. They sent them back. And with that, next we put people into 4 buckets. Lowest risk group, no screening until age 50. The average risk, biennial mammograms, meaning every 2 years. It was sort of the average, which is actually what the U.S. Preventive Task Force guidelines recommends every other year. And elevated risk was where we really felt that people needed to have more frequent mammograms every year. And the highest risk were mammograms alternating with MRI. In these top 2 risk groups, we invited everybody to talk with a breast health specialist and to use our breast health decisions tool. And this included all of the pathogenic variants were in this group. So everyone who had high risk, and we're going to come back to that because that's actually important. Okay, so that's the model. Everyone understand the model? Yeah, and so then what we did was we put all this into our breast health decisions tool where we could say, okay, here are the risk factors, here they are in context, here's what you can do to reduce your risk if your risk is high, and how that might help you, and try to encourage people to do things like think about their diet, think about exercise, and think about especially if they're at risk for, hormone positive driven tumors, which we can know that we have lots of information about that from your polygenic risk and from certain pathogenic variants or the errors or mutations in the genes. We could recommend specific risk reduction. What about low risk after 65? Was one of the questions. So currently, that is every other year, but it's actually a very interesting question because we do have people in the population whose risk after 65 is extremely low. And those are probably going forward, people in the population who could probably screen every 3 years or even stop screening after 65. There is a study in the UK, I'm sorry, in Europe, the MyPeb study, where they are taking the lowest risk group and having them screen every 4 years, essentially. So we'll see how low that risk is. And if that actually turns out to be important, we can make that kind of a change. Okay, so the next slide, what were we looking for? We wanted the most important thing that everyone is asking. This is sort of where we were criticized that, oh, we were going to put people in harm's way and there were going to be all these new stage 2B cancers. So the most important thing, if we want to think about doing risk-based screening and not making it one size fits all, we had to show that we wouldn't increase the risk of having a stage 2B or higher cancer. And stage 2B is really where you have node positive disease or you really start to see a difference in survival. We'll come back to that kind of at the end. And then the other question was, would this reduce the number of mammograms people had? Would it reduce the number of biopsies and false positives? Would it encourage prevention? And would people accept it? Would people be willing to be randomized in the first place? And what happened in the observational group? Did people want to do it or not? So at the end of the day, you want to see, would this be a better way to think about introducing screening? So next slide.
Just one question in the chat. If we considered parity, breastfeeding, obesity, and smoking, did that determine our risk, someone's risk?
So obesity or body mass index was not in this particular model, but it is in the Wisdom 2.0 model. We do ask about smoking. Smoking probably does increase your risk of triple negative or the hormone negative breast cancer. It's not a big driver of that risk. Parity is actually included in, and especially age at first pregnancy, which is also a really interesting question because, the actual average age that people have their first child now has really changed pretty dramatically. It's now 32. And so people are having their kids later in life. So some of that early risk reduction from early having kids early is gone. So we have to think about ways in which we can adjust to that. We're going to talk about that at our next Rise Up for Breast Cancer and Women's Health meeting in next April.
And the other one was benign, history of benign biopsies, which yes, but biopsy results are part of the BCSC model.
Yeah. That's actually part of almost all of the risk-based models. Yeah. So our first, again, rate of stage 2B or higher had to be, when we say non-inferior, couldn't be worse. So we had this margin. So where we said it would be unsafe is if there had to be less than one additional stage 2B cancer for every 2,000 women screened. So that's a pretty stringent risk. Okay, next slide. And here you can see here's our results. So we registered about 77,000 people. Next slide. Everyone learned about the study online. They registered online. They were invited to choose whether they wanted randomized or observational, and then they consented online. 61% agreed to be randomized. And interestingly, that was sort of what our pilot showed. So that was very consistent across all the years of the study. Next was, of the people, though, who chose to pick their own arm, 89% picked risk-based. And that was true. I mean, while there were small differences here and there, I mean, basically it didn't matter whether you were Black or white or Hispanic or Asian or young or old. By and large, most people liked the idea of a personalized approach to screening, which makes sense, right? I think women can understand this, even if everyone in the profession couldn't get behind it. Next slide. So here's the information about the risk-based screening arm. So I'm not going to show you the results of the annual screening arm. Of the non-randomized one, because that doesn't allow us to strictly look at the results. What this allows us to see is, okay, in the people who are randomly assigned to either risk-based or annual screening, how safe was it? And did we do a good job of reducing these more aggressive, higher stage cancers? So interestingly, only 2% were assigned to the highest risk group. 8% were in the elevated risk group. So 10% of people were in the higher risk groups where we were really kind of pushing risk reduction. The average risk group in this were 62%, and about 26% of people who were enrolled were told not to screen again until 60. But of the people in their 40s, it was about two-thirds of them were
And
told they
screen
they
until
were
50, not 60.
until, sorry, until 50.
50.
Yes,
Yeah.
yes. Okay. So go ahead. Next slide. So again, 10% were high risk. So the most important thing was, did we do a good job? And here you see the black line is the annual arm, and the red line is the risk-based arm. In fact, we lowered the number of stage 2B cancers by a third. Now, next. So go ahead. Click, click, click. So the most important thing here, though, is right here, the highest risk group here. This was the people who screened every 6 months that we identified were in that very highest risk group. They had no stage 2B or higher cancers. So we did a very good job of finding the people who were most at risk for these bad cancers. And in fact, we significantly reduced the chance that they would have a higher cancer. The highest rates of stage 2B cancer were in the elevated group, the people who were in that group. So there's some room for improvement there. Next is you see the average risk group, and which were substantially lower, and then the lowest risk group. There were like 4, I think, total cancers that were stage 2B or higher. And this is in the annual arm. This is the average, and these two are well below that average. So next slide. So certainly safe. Now we could ask the question, also, was the stage 2A cancers, did we increase those? And again, the same story. Most important here is the number of cancers in each group were the same. But when you look at the number of cancers, they increase as the risk increases. So the highest risk people had the most cancers, the elevated risk, the next most, and then the average risk after that, and then the lowest risk group. So I think we can safely say that this did a really good job. This is our first model, comprehensive model, and it did a really good job of saying who was at lowest risk and who was at highest risk. I think that's really, really important. And you can see there's just many more of these cancers. And the fact that we didn't get any stage 2B in this group is really, I think, important. Next slide. Another really common thing that criticism of screening has been that we're just increasing the number of low risk cancers, but not decreasing, and by the same measure, the number of high risk cancers. But here you can see that we increased the stage 1 cancers in the risk-based arm, but we actually reduced the risk of the stage 2B and higher cancers. And this is shown in the next slide. You can see here, focus on, you'll watch, this is the annual group, and I'm going to show you the risk-based group. This number is going to go up, and these numbers should go down if that's actually, in fact, what happens. So click again, and you'll see these numbers going down at to the same degree that these are going up. So it's telling you that you're exchanging, the consequential cancers, and you're moving those down, and you're just not flooding the group with lots more low-risk cancers. Next slide. So this is what we wanted to avoid. So this is what the results of all the screening were, is you've got a lot of these early stage cancers, but not anywhere near as much of a drop in the late stage cancers. So that's what we were trying to avoid, and we did that also. Next slide. Another really important thing is that the MyPab study, which is in Europe, right, that I just talked about, they actually had, this is really a complicated slide to look at, but they were not looking at the pathogenic variants. And so they wanted to know, did we really think that finding these finding the women in the high-risk screening group, could they be found either looking at the BCSC model alone or BCS plus PRS? And in fact, less than 1% of patients, just this group, was identified by the BCSC and PRS. So none of these people would have gotten actually high-risk screening if we had done this. And most people wouldn't even have gotten the annual screening mammography. These are women 40 to 49. So we wouldn't have told this huge group of people here not to screen until 50. It's just, this is counterintuitive. So if someone had a pathogenic variant or had one of these cancers in BRCA1, BRCA2, CHEK2, PALB2, we would not have been able to find them by the clinical model alone, the polygenic risk score combined with the clinical model. And that was true also for this high risk group. Very few people would have been found by those models alone. And what that shows us is that the genetic testing really contributes an equal amount of information that's really very separate. 65% of our highest risk people got there because of their genetic testing. And 30% of people did not have any family history. That was also a big surprise to everyone. And that's one of the reasons why we've changed to actually go back to giving people, uh, to thinking about, wow, what should we really be doing? Well, probably the most important thing for us to do is find those people at very highest risk, but we don't have to wait till 40. You can do this genetic testing at any age. So if we do it at 30, you know, probably a third to half of people with these pathogenic variants get cancers in their 30s. So we really wanted to find those cancers early. Okay, so next slide. So if I were to summarize, so again, most people were able to accept personalized, we're happy to do personalized screening. It was safe. Did not increase the stage 2B cancers. In fact, we actually were able to eliminate the stage 2B cancers in that highest risk group. And, I think most importantly, we didn't see an increase in advanced stage cancers among women assigned to less intensive screening. Um, and that I think is very important. We weren't able to decrease the biopsy rates as much as we wanted, but of course, part of the problem is that the biopsy rates depended very much on the risk groups that you were in. The highest risk groups, people had high biopsies, and where we want to really make a difference is try, it's almost like you had to run this trial to reassure people that it's okay to do less screening, that's actually that's a very reasonable choice. So I think that's just an important lesson. We would say that 77% of people could complete their saliva kits at home without a problem, so they accepted getting genetic testing. Turns out that about 1 in 40 women carries one of these errors in one of the genes that really increases their lifetime risk. And 30% of those people didn't have any family history of breast cancer. And as I just showed you, that information about the genetic testing is an independent way of finding people at highest risk. And I think is a very, very important part of risk-based screening. And I think one of our biggest tasks going forward is going to be to try and get this part of screening. I see you want to hear more about the false positive risk. So you'll notice that there were only 2% of the population that we recommended MRI screening for. There probably is another couple percent that we probably need to add in the elevated risk group and move that up. One of the reasons why we don't want to do a lot of MRI screening is that you can have the false positive rate's about 40%. So it's about 25%, 30% for mammograms, and it's about 40% for MRI. So this is, population-based screening is it's a public good, right? So you're not you're trying to decide how you should manage a whole population. So if you have a test that finds all kinds of false positives, you don't want a lot of people to get it who wouldn't be likely to benefit. And that's why that whole idea of trying to be more thoughtful about who gets more is very important, and thoughtful about who gets less. And so you want it to be safe on both ends. Does that answer your question? I think the other thing is that, we've shown in other models too that you can actually get this. If I don't know, Allison, do you have the summary slide um, with the Kaplan-Meier plots on it? Maybe not.
I think so.
That's okay. I mean, I think that if you were to do this in the population and said, well, wow, this is really where we could reduce the chance of finding, if we could reduce by a third the number of stage 2B cancers, I mean, we could save 5 to 6,000 lives a year. So it's, I think, and we could do it at less cost and do it with less, you know, uh, less burden of screening for everybody. Okay, so the next slide. Um, so this first model is not the end. I think the thing that's exciting about it is this is a platform where we can say, okay, this is great. Now, how can we do better? So we can do better by trying to figure, well, who are those people wisdom in wisdom one? So in that elevated group, that second highest risk group, how can we try and figure out how to find who should be screened more frequently? And so there's a couple of ways in which we can do that. And I think I have a slide coming up about that. Next slide. So I think it's worth reflecting on what made the study so hard to conduct. And I think part of it is the inherent bias of the radiology and oncology community is very strong, certainly was very strong. People have come to believe that a cancer detected is a life saved. But that's not really what the data says. The data says that, you can reduce the chance by about 20 to 30% of having that. So it often relates to like about a 4% difference. The biggest gains in dropping mortality is from treatment. That doesn't mean screening doesn't have any benefit, but you want to be careful not, it's not like, okay, everyone should have a mammogram every year, and that's the only way we can do it. We can do better for sure. And yes, Wisdom 2.0 is still enrolling, although we are currently taking a pause till we raise some more money to pay for the genetic testing until we can get it standard of care. But you can still enroll and put yourself on the waiting list any day now. We're going to get someone to really invest in our trial. Okay, so next slide. So this was an article that was actually published in Breast Cancer Research and Treatment in 2021. I actually didn't see it, and it was pointed out to me by one of our advocates. Dan Kopens used to be head of breast radiology at Massachusetts General Hospital, and they published this article that said the Wisdom trial is based on faulty reasoning, has major design and execution problems. And it's interesting, Dan Kopens had been criticizing what we've been doing for a long time. So I wasn't particularly surprised to see him submit such an article. But what really surprised me was that they published it. They published it without talking to us or even checking the basic data. And what that again showed me or showed all of us in the community, that there's just an inherent bias, that the oncologists are afraid, that we're going to be exposing people to risk and that we shouldn't be doing it. And nobody checked. They had things like, it doesn't have a statistical plan. Well, our statistical plan was published actually. When they said, it wasn't reviewed by an IRB, it actually was reviewed by 3 IRBs, and so on and so forth. There were about 20 of these things. So we wrote an article. We actually tried to get this pulled but retracted. But the journal didn't want to do that. So they gave us, next slide, a full page ad. And we wrote again with all of our investigators and all of our advocates, a full page ads and saying that, no one's being forced to join a trial. with informed consent, and we shouldn't we shouldn't be afraid of asking the question, can we do better than we're doing today? And I would say if screening today were so perfect, there wouldn't be 40,000 women dying of breast cancer every year. And I run this I-SPY trial, which is for people with stage 2B and higher cancers. There would be no such trial if screening were perfect. So it's not that I'm against screening, I'm against not making it better. And so that's um, and so I think this is really important to check your biases at the door and say we are allowed to try and make things better. Um, you know, um, Next slide. And I think that some of this is, you know, every time a celebrity gets cancer, they say, oh, go out and get a mammogram, right? And there's 350 cases of cancer every year and 40,000 women dying. Getting a mammogram every year isn't going to solve the problem. We have to find the people at highest risk, and we also have to try and help people who are getting overdiagnosed with some of these smaller cancers like DCIS and try and keep people from being overtreated as well. Next slide. And this is the problem that we were trying to address was, we weren't putting our advances in cancer prevention together, or the advances in risk assessment, or the fact that, people could be protected um, from getting discriminated against by knowing their genetic risk. And as the advances in technology came in, and as the Supreme Court said that, Myriad couldn't own the genome, it really opened the door to doing low cost, low pass whole genome sequencing, as well as the pathogenic variant sequencing. So it went down from like $3,000 down to like $200 or $300. So that suddenly made things much more accessible. So you could get this genetic testing. It's a one-time test. You can get it for the price of a mammogram or less than the price of a mammogram. And we weren't trying to think about it like, how do we find the people at highest risk and at least get them, you know, inform them and get them into a different kind of screening program. Next slide.
And Laura, that's a segue into one of the questions. Are you planning to publish a cost effectiveness analysis for at-home saliva genetic testing based on the data?
Um, we are actually publishing, we actually had a poster that we presented to show that of all of the screening guidelines that range anywhere from $7.5 billion a year to almost $30 billion a year. So Wisdom is the most cost effective, and the American College of Radiology approach is the most expensive. And that's a lot of money to spend every year. And, if you were running a business and you were spending $20 billion, you really would have to show, what are you doing for that? And are you doing a good job? And so we have to be thinking about that, because there's lots of other things that we'd like to invest resources into to try and improve outcomes for people. So next slide.
And so that poster will be turned into a paper soon.
Yes.
In the works, yes. And
It's
then
in
one
the
other
works.
question, has the Wisdom team been able to debunk all of the criticisms, or are there still lingering doubts?
Well, yes, we've debunked all the criticisms, but I would say that, your mind has to be open. I think one of the things that I had thought, I was really hoping that Dr. Kopens would still be alive and well to see the results of Wisdom, assuming that he would actually be interested in the results. And that actually showed my own naivete, So before we even had a chance to present the results in December, the American College of Radiology put out a statement about what was wrong. And Dr. Kopens, wrote some ridiculous comment that Wisdom should stand for when ill-informed surgeons don't understand mammography. But, sticks and stones. The young radiologists and the new leadership in radiology understand that this is the future. And, mammographic AI and different tools to be able to predict who's at risk is coming forward. And, Chicken, you're asking, what are the incentives around bias? Well, I think the radiologists are concerned that they're if you don't, if you can imagine, we would reduce the amount of mammograms that would be obtained.
We lost her. Can you guys hear? I think she just got paused. Okay. Laura is
Yeah, she's frozen.
frozen. Okay.
Yeah.
I think what she was saying. Oh, there she goes. Oh, you're back. Yes. Can you hear us? Okay. What she was saying was that the incentives for both the medical center and radiology is the fewer mammograms you do, the less revenue you have coming in if you reduce the numbers. And so there's a sort of a business objection to going with a risk-based approach. But again, it's not better science or better medicine. It's just because of the loss in revenue, which is unfortunate. So yes, there's still it is incentivized to do those services, but we are working to hopefully get that less of a priority and more trying to get better outcomes and have it be outcomes based rather than service based. And it looks like Laura is slowly coming back online. There were a couple other questions that maybe
Yeah.
we could address
So
for a second.
can you
She's
guys
back.
hear me?
Yes. I think
Somewhere,
I answered the question.
somewhere near Silicon Valley. But the thing is, I think people, this is not uncommon. People get nervous about their profession that you're going to lose your ability to do the things that you do. But things change. I always say when I trained as a surgeon, all of the procedures that I learned how to do, nobody does anymore.
Mhm.
But things move on, and there are new things that replace what you do. And so you can't, you have to be an advocate for your patients and the people you're caring for, not your specialty. And there are, everyone's got a brain and everyone can be trained to do new things. And you have to be willing to take a good hard look at what you're doing to try and find ways to improve it. I laugh and say when I first pitched this trial, I used to say we should demand the iPhone 8. And here we are, the iPhone 18, and we're still not adopting risk-based screening. But anyway, but that's
Um,
okay. I mean, that's okay. Our job is to just keep your head down and keep doing what you're doing and sort of work on. I'll show you some of the things that we have to do to make this go.
Before we move on, there's two more comments that are relatively related. One is confirming that density is part of our model. And yes, it's part of
Yes.
the BCSE version 2 and the BCSE version 3. So we've used that
However,
since.
however, there are better ways to look at density. And in fact, the recommendation that everyone who has dense breast tissue gets an MRI is really misguided because that's half the women. And if you think about all of that, all of the false positives that are associated with that, half people do not need MRI screening. That actually would be a very big mistake. Coming down the pike, hopefully by the end of this year, is mammographic AI as a tool to assess density. And mammographic AI does two things. One is it probably sees better, and you can identify people who might have a hidden or masked cancer. That would be your 1 year risk, but it also contains additional information about risk that can be combined with our polygenic risk scores and our genetic information. And I think will lead to an even better model for, be a big improvement, which I'll show you in a little bit. What was the next question?
You answered
Oh,
it. It was your thoughts
oh,
on doing MRIs for people
okay.
with density C and D. Mhm.
No, I think, absent anything, I would not do it. I think you can do it for the highest risk density, but also it depends on what other factors that you have. But this is one of the reasons why I'm such a strong believer in genetic testing. I was on a National Institutes of Health, of the National Academy of Sciences panel to look at genetic testing back in like 2012 and 2013. And that was sort of, we just said, we just have to get around to doing, testing for everyone. Um, so I think that, for extremely dense breast tissue, it's not unreasonable to think about MRI screening, but again, mammographic density is going to be here in the next 6 months or so. And there are already algorithms that are out there. So again, I think that's what we tried to do in Wisdom. We tried to think about integrating risk assessment, screening and prevention, and trying to do a modern era trial that allowed people to join regardless of where they get their care, try and make it more accessible to everyone. And most importantly, and we have more work to do on this, but try and find the women at risk for aggressive interval cancers that show up between screens. And no matter what, the most important thing for women to get out there is like any woman, no matter what, has some risk of getting breast cancer. If you feel a mass, no matter what kind of screening you've had that was normal, if you feel something new, you need to get it checked out. It's really important. Okay, we're going to talk about this. And, a lot of people would say, wow, I don't want to participate in a study. And I think one of the reasons why we started this forum was to try and debunk the myth that studies are guinea pigs and we don't really want to uh, be part of studies. But, you know, we learn so much from studies. We learn things we didn't know. When I started my career in breast cancer, death from heart disease was by far almost threefold higher risk of dying of heart disease and cancer. But because of the Framingham study that really learned how to do individual risk assessment over time, they learned how to reduce the risk of dying of heart disease, finding intermediate or early markers like cholesterol, like blood pressure, and giving people medicines for decreasing their blood pressure. All of these trials and showing that these intermediate markers led to lowering of the chance of dying of heart disease has made it so that breast cancer, or cancer deaths are now the same as heart disease. So we need to be, jealous of the cardiologist and work on getting that blue line way down. Next slide. Next slide. So we had to build a culture, and that meant getting our advocates, our wisdom ambassadors from every walk of life, from every color and every race. Um, uh, and, thanks, Lisa. And then to get women excited about building a better future for themselves, their friends and family. As I said, demand the iPhone 8 or 18. And I think we need to just reframe the concept of risk. And I'll talk about the guidelines in just a second, Tegan. And then next slide. So I think this is like when people say, well, why do we need something different? That block cell phone is what I thought was such when I was an intern. That's what I had. My dad got me one because I spent my dinner in the phone booth. And this is uh and no one's afraid of technology that helps them. So it's like you've got to do better. We've got it. Most advances in medicine for women have come from women themselves. So next slide. This is Allison in South Dakota, where pre-TSA is even up there. No one's if you have the chance to be able to be pre-screened and show that your risk is lower so you can get through faster or do less, that's good. That's part of our whole ethos. That's good. And we want to think about that. Not that every screening test is perfect. It's not. But, we don't treat allergies the same. This is, if you had too much pollen, you would take an antihistamine. If you had allergy or asthma, you would use an inhaler. But if you were allergic to bee stings and got stung by a bee, you would have an EpiPen. So there is no disease where one size fits all. So screening shouldn't be that. We don't tell women to go out, next slide, and get a pair of size 8 jeans, right? Everybody is different. So we should be looking at that. And it's not that it's going to be perfect, right? But we can keep building on it. So keep going. Next slide. Next slide. So I think one of the big problems is lack of diversity early in the trial. We opened it up to everyone. We thought everyone would come on the trial. Did not happen, early on. And we know already that Black women have a higher risk of bad cancers earlier in their lives, in their 40s and 50s. And so we didn't want to have a trial where they were left out. And if you look at, and this is Black women, if you look at, persons of European ancestry are 16% of the global population, but make up 70% of risk studies. And as my friend Kim Badal says, no participation, no representation. So we really embarked on a whole effort to try and make sure that we are making this more accessible. This is an article that got written up in Stat Magazine. I always laugh at this. Anyway, but we did, next slide, will show you this is because we actually talked about how the fact we were at 1.7% Black women in the trial, which is terrible. By the end of the trial, when we closed it, we were at 17.5%. And, we wanted to get to that 14% or higher. And the same thing that we saw next that we wanted to increase, we could still do better with Latino women, and Asian women. We should be able to do better because it turns out that you learn from everybody how to do better at advancing or finding out which cancers apply. And that, the more you understand about predicting risk of triple negative breast cancer, you're also helping the women who are white who are at risk for triple negative breast cancer. So next slide.
And just before we move on, I just want to give a quick shout out to a few of our community leadership board members who are on, who have been part of this
Absolutely.
process since the beginning. So Wilma and Marion and Lisa, who are on. I think I've caught everyone. If I've missed you, I apologize. But really bringing together community leaders to develop strategies to try and reach out to women, to meet them where they are in the community, and to try and develop ways in which we can message the opportunity, but message, the contribution that women can make, that's culturally appropriate, relevant, meaningful to various individuals. So just wanted to shout out our community leadership board members who are on.
Yeah, and it's, I wanted to fix it in a year, but it's not a 1 year fix. But I would say in our Wisdom 2.0, we are really doing really much better in recruiting. And a lot of that is because of our collaboration with the VA, because I think it's important to overrepresent to make sure that we make up for some of the underrepresentation in the past. And, with our new low pass whole genome, we can actually look at ancestry directly now and sort of think about this. So this is, how do we do this relentless communication, constantly talking about this and talking about how important it is and how important it is to build a community of women who are out to help other women and make it better. It really, I agree with you. It truly takes a village. Hundreds of people working on this. But I do think it's true that this is about us helping each other and coming up with things that are better. Next slide. So we moved the age of enrollment down to 30. And so this is our enrollment page. But I would say attention to implementation is really critical. So how are we going to do this? The biggest problem is that genetic testing isn't covered. And we have to figure out how to change that. So the next slide says we can't do it without that. Because if we thought running the study was hard, figuring out how to drive implementation and changing the standard of care is even harder. And wisdom isn't just a test, it's a process, right? So we have to take what's proven. We have to try and do demonstration projects with health systems, get population genetic testing covered starting at 30, integrate tools to automate the acquisition and tracking of mammograms. We've now developed this image repository so we can do this. We we have to, we're updating our breast health decisions to make sure it stays current. We have to integrate the recommendations into the electronic health record so our primary care physicians can see this information for their patients. And we have to track the outcomes and our impact. So there's lots of work that we have to do there. The other thing they're doing is Wisdom 2.0, because we're not done. So the idea is if you have programs that are implementing it, as we learn that things work, we can throw it over the fence and start constantly building something that will work. Most important thing is to predict fast and slow growing tumors. If you are at risk for having a fast growing cancer, you have to be screened more frequently. And if you're at risk for a slower growing tumor, being screened every 2 years, even if your risk is higher, is probably going to be just as good, because finding a tumor that's 2 centimeters is the same as finding a cancer that's 1 centimeter in terms of what our treatments are and what our outcomes are. Um, so integrating mammographic AI, we are really excited to say that we've are integrating, pulling in all of the data from Wisdom 1.0, and will help us actually understand how mammographic AI contributes to all the other things that we've done. It'll save us like 7 years worth of research, and we'll be able to do it in about a year. Um, I think covering the cost of genetic testing is absolutely critical. Next. So we have to get that breast health decisions tool into the electronic record, as I said, even integrating, showing that what we are doing, step up our risk reduction counseling and track outcomes. And just like people who are reluctant to think about risk reduction, we're reluctant to think about risk-based screening. If you are at risk for a hormone-positive cancer, if there are easy things that people tolerate to reduce risk, we should think about it. It's like taking a statin to reduce your cholesterol risk, or to reduce if you have a family history of heart disease. It drops your chance of dying of a heart attack by 30%. That's a lot. Now, I think one of the issues in breast cancer is, does it really reduce your chance of dying of breast cancer, or does it reduce your chance of ever having to go through a treatment and the concern? So they're not necessarily the same. So these are things we have to continue to look for better tools. I think that the most important, I think, Tegan, you asked about this, someone else also asked about this, we have to change the guidelines. The U.S. Preventive Task Force, if they make a decision that this has to be covered, and that the wisdom study results would justify having risk-based screening, it has the force of law and it would have to be covered. Now, the problem is the U.S. Preventive Task Force isn't currently meeting, and we don't know. They fired the senior leaders, and hopefully the new leaders will come, and hopefully that they will meet again in a year, within the next year. But that's a problem. We're trying to work on the National Comprehensive Cancer Center Network guidelines, the NCCN guidelines. We hope that when they meet in the fall, they will say this should be an alternative, and to make this go forward. I think thinking about a demonstration project with Medicare, with Medicaid, because the government does pay for the lifetime screening for underserved women, and having something that's more effective and less expensive is in their interest. And also, if you've got a lot of other things going on, it's nice to know, you really want to focus on the people that need to get in and get screened. Um, I think that is super important. There is another very big problem that we've just discovered. So the HEDIS guidelines had said you have to get, this is really how most, the National Center for Quality Assurance kind of does a grade for every organization that does screening or does healthcare delivery. And it used to be that screening every other year, starting at age 50, was the standard. But because the U.S. Preventive Task Force changed their guidelines at the end of 24, they changed their guidelines. So now it says that everyone has to get screened starting at 40. And so in order to implement what we do in Wisdom, we have to make that change. So we're talking to the leadership at HEDIS and hoping that they will upgrade this. But the other thing we have to do is to um, so Wendy, I'm going to address that in just a minute. Adding ultrasound is not the right answer, but uh, it turns out the statute for breast cancer screening says it's a mammographic test. It's not risk assessment. For colon cancer, for prostate cancer, you can use some kind of risk assessment. But for breast cancer, they don't have that language. We have to make the language change so that we can use something like Wisdom as part of Medicare, as part of Medicaid. And why that's important is so goes Medicare, so goes so many of the other insurers. So there's a lot on our plate that we have to change to make this um, a reality.
And
Um,
Laura, I added a couple more things in that I think are similarly important with provider adoption and education, particularly around what is polygenic risk and some of the components of that, as well as what you talked about of sort of unwinding the public health messaging of screening saves lives. I think trying to reframe messaging, smarter screening, risk-informed screening. So there's some sort of messaging and socialization around these results too that I think have to happen both for providers and for women themselves.
and I do agree with your last point is that, I mean, all of the, people get their information from many sources, right? So if you go to get your screening, you'll get a letter often from where you got your mammogram that says, I'm a member of the American College of Radiology, and I think everyone should come in every year. So come back next year. And that's anxiety provoking. If you're told maybe to come back in 2 years or not come back till 50. So I think it's really trying to get people more on board. We were just talking with one of the kind of up and coming radiologists who wants to partner with us to, have the American College of Radiology lead more risk-based screening initiatives, which I think is great. But I think we almost had to do this trial to show actually, not only are we not increasing the chance that someone would show up with a stage 2B cancer, we actually are reducing that chance by a third. That's just so important. And I think finding people at a young enough age so that they know if they have an inherited mutation where their lifetime risk is 60 to 80%, that's huge. If you're BRCA2, there are things you can do to reduce your risk by taking, low dose TAM or things tamoxifen, baby tamoxifen. But if you're BRCA1, we are starting to come up with new strategies for breast cancer risk reduction so that people don't necessarily have to think about prophylactic surgery. But people need to know what their options are, and people need to know too that they don't necessarily have to pass that if they don't want to, they don't have to pass those genes on to their children. That you can do in vitro fertilization and you can do pre-implantation genetic testing. These are things you can do. It's not things you have to do, but they're things that you can do. And I think it's just so important that we give people the options to do better if they want. So I think again, all of us together have to find a way forward. Um, it's gonna still be a lot of hard work.
Yeah. I know that we are out of time. There is a link in the chat to an evaluation. There was one comment earlier that didn't get addressed, and it's about if you were able to show the percent in the low risk category that were ultimately diagnosed. Um, and one update too is that we are continuously evaluating the data that we have, and also we are asking for additional follow-up data for those who have been part of the Wisdom 1.0 cohort. So each year we have another data lock and another review of the data. So these results will continuously be updated as we get additional follow-up data from our participants, and we'll be looking at additional results so we can share out.
So I'm going to answer just a couple of very quick questions, and certainly it's extremely unusual. I mean, I'm sure people know people who have gotten breast cancer in their 20s, and there does seem to be a little bit more of it, but it's still quite rare. Um, what we're going to try and do is at least start with trying to make sure that we can get this information to people who are 30 and to start with that. That I think is super important. It also turns out that if you are at high risk, that ultrasound is not really the right second test. You need to get some kind of contrast imaging. So ultrasound, like mammograms, are looking at ionizing radiation, that kind of hit dense breast tissue and reflect back. So one uses ionizing radiation, the other is using sound waves. But contrast imaging is looking from a different perspective, looking at how much the breast tissue takes up contrast material from the blood, and that shows you patterns of uptake in that. You can do a contrast-based mammogram. You can also do an MRI. There are MRIs that are fast that are going to be better. I think starting in the middle of next year, that will be the standard. So it will be better over time. They're really cool tools that people are working on projecting what the imaging will look like uh, without having to do the IV contrast. That's probably 2 or 3 years away, but they're coming. And these kind of cool innovations are coming. Um, but anyway, I would say, so we have a pretty big team working on it, but unfortunately we have to we just we have had to raise the resources to do the genetic testing because we couldn't get because that wasn't covered as part of the grants. But we're committed to finding a way to do that and keeping on. And we really appreciate the community being with us. And we really are super grateful to all the people who participated in the study. Without them, this critical information would not have come forward.
And also to those who maybe weren't able to participate, but shared the opportunity out to friends and family, and helped us get as many participants as we've had and continue to bring in. So thank you to everyone for joining us. Thank you, Laura,
And
for the great overview
aspire
of the results.
aspire to be better. That's what I say. We can always aspire to be better.
Yeah.
And we can't let the naysayers stop us.
Yes. And next month, our forum is on Monday, July 27th. I think the topic is still TBD, but part of the TBD is we want to hear from you and figuring out what topics you would like to hear about. So that the survey link is back in the chat if you could let us know both feedback from today as well as future topics. As I mentioned, these are just the results as of now. There are many, many more results that will be coming forward. If there's a question that you have that didn't get answered or wondering if we're looking at one thing or another, feel free to suggest it and we can let you know if it's something we've already looked at, plan to look at, or would be
Oh,
something that
we
we
should
can
do.
look at together.
Let's have a Rosh on next month and let's show the website the information that we want to show about how to explain, how to make sort of just some simple ways of presenting the information on the breast health decisions tool and on our website to show people the results without getting into all the nitty-gritty details. We
Yeah,
were going to do
excellent.
that, but we didn't have time to do it. But let's hear from you guys, especially those who've been on this and you've gotten to see more of the results. We'll see if our simplified version of it does the trick and makes people feel more comfortable. We have to make women feel more comfortable. We have to make the providers feel more comfortable. But it has gotten a lot of attention, and one of the oncologists, got up and said that this was the most important study of the year, and this is, I think that I think people were surprised, you know, by the results. I think even we were surprised at how good they were, but it's but
Just
I think it's worth that shows how important it is and how worthwhile it is. Yeah.
Just
Okay.
for fun, I put up some pictures of the presentations at San Antonio and ASCO, which are two of the biggest meetings in cancer of the year. Some of the papers that have been published, and these are linked out on our website as well. Yeah, so lots of media that picked up the initial results back in December as well. The Time Magazine, New York Times, Washington Post. So now it's, I think, upon us to simplify the results and really be able to put the changes into practice by working with all of the changes that need to happen, Laura mentioned. So with that, thank you everyone so much for joining us. We will wrap up for the evening and for the month. I hope everyone has a wonderful rest of your night. And we will talk
Oh,
again in
we
July.
can. So I think we can do this maybe.